Great. So, so today we're going to talk about insulin pump fundamentals and some carb coverage strategies. Megan and I'll present the first half, and Megan will present the second half. And I think we are both super excited about this topic. Here are disclosures for today. And this is what we're hoping to accomplish. So my number one goal is to demystify insulin pumps. Because they can be kind of intimidating, but they really shouldn't be. We're going to learn the fundamental principles of how an insulin pump works. So this will allow us and you to kind of learn the language that we speak when we talk about insulin pumps. And then we'll talk also about determining if a patient with type 2 diabetes is appropriate for an insulin pump. And then some time on carb coverage strategies in your practice. So I always like to talk first about principles of fast-acting insulin. And my goal or my hope is that what's going to come after this will be so basic for everybody that this is just automatically things that you know. But speaking from my own personal experience, I did not ever have instruction in this way when I was a medical student or even as a resident, and I basically just learned it on the fly when I came into practice. So some of you just might find this so easy, and some of you hopefully will find that it informs the way you think about insulin, because you have to understand fast-acting insulin to understand insulin pumps. So the first thing we're going to talk about is carb coverage. So carb coverage is just the amount of insulin that is necessary to take for a meal. So in an ideal situation, the blood sugar in this case is normal. It's 100, and the patient is going to eat something, and there's going to be some amount of insulin that they're going to take before. We're always asking patients to take insulin before eating. And then if everything works out perfectly, 3 to 4 hours later, if they took the right amount of insulin or what they were eating, then their blood sugar will be still normal later. So that's the goal, right? So it seems pretty simple. But we have to apply a carb ratio, and a carb ratio is just how much insulin is required to cover a certain amount of carbohydrates. So if the insulin to carb ratio is 15, then 1 unit of insulin will cover 15 grams of carbohydrates. And if it's 5, then 1 unit will only cover 5 grams. So if we go back to this example and we say that this hamburger, or whatever it is 60 grams of carbohydrates, and we say that this patient has a carb ratio of 15, well, then that dose of insulin that they need is 4 units. And with that 4 units, their blood sugar will be normal after several hours. So that's carb coverage, and we'll talk a little bit more about that. The next issue is correction. So we talk a lot to patients about correction. And in this case, the patient still wants to eat. They're having the same thing, but their starting blood sugar is 300, right? So if we take their carb ratio and apply it to how many grams of carbohydrates they're eating, they're taking 4 units of insulin. But if they just take 4 units of insulin, then they've prevented their blood sugar from getting worse. But it's still going to be 300. 3 to 4 hours later. So we have to do something about the fact that when they began, when they sat down to eat, their blood sugar was already 300. And that's what correction is. So if we take their blood sugar of 300, we're going to ask them to give some insulin for that blood sugar. And ideally, after 3 to 4 hours, their blood sugar will normalize, and we've sort of arbitrarily set a target of 100 here. But same issue. So how are we supposed to know how much insulin it would take for a person to bring their blood sugar from 300 to 100? And so this is where we get to a correction factor. And we call this also an insulin sensitivity factor. The terms are interchangeable. You'll see them used in various places depending on the context, but they mean the exact same thing. And this is just, if you give a person 1 unit of insulin, how much will their blood sugar go down? And makes it more difficult that it's different for every person. So examples here, if the insulin sensitivity factor is 50, then we would expect 1 unit to lower their blood sugar by 50 points. If it's only 25, then it would lower their blood sugar 25 points. And another way you could say that is that 2 units would lower it by 50. The only reason I mention that is if you are familiar with sliding scales, that's often how they're structured, right? So it will, if the blood sugar is between 100 and 150, then you wouldn't do anything. If it's between 150 and 200, then that would mean the patient takes 2 units, and 250 to 300 would be 4 units. So that is where that comes from. That sliding scale is basically based on an insulin sensitivity factor or a correction factor of 25. And we try not to, people are trying to get away from using even the terminology sliding scale. It's still used all the time, but it's really just based on a correction factor. And if you have an insulin sensitivity factor of 10, then 1 unit will only lower the blood sugar by 10 points. And so it would take 10 units to lower it full 100 points. On the other hand, you'll see patients with an insulin sensitivity factor for 100, in which case 1 unit would lower their blood sugar by 100 points. And that can be a trickier situation, and these patients are more insulin sensitive. You'll see this especially in pediatrics, and then I see it a lot in my older patients. They tend to become very insulin sensitive. So back to our example. This is an example where the correction factor is 50. And so if we say that the target is 100, then we need to lower the blood sugar by 200 points. So 300 minus 100 is 200. And then we take that 200 and divide it by 50. And so that's 4 units of insulin would be expected to lower the blood sugar by 200 points down to our target of 100. If it's 20, then we do the same initial math. We take the blood sugar minus the target, which is 200, and then we take that 200 and divide it by 20, and that's 10 units. So in this case, it's 10 units for this situation. So now we're going to combine all of this together. A situation where a person their blood sugar is 300, and they're eating 60 grams of carbohydrates. So for that 60 grams of carbohydrates, with a carb ratio of 15, they need 4 units of carb coverage. But for the 300, their blood sugar is 200 points too high. And if their correction factor is 50, then they need 4 units for correction. So the total dose in this situation is 8 units, 4 units of carb coverage, 4 units of correction. And if we did all of that correctly, patient has a normal blood sugar several hours later, even if their blood sugar was high when they were eating. Now, those were all idealized numbers, right? So in the real world, the problem is the math gets much more difficult, right? So we start picking some random numbers of blood sugar of 327, and maybe they're having 92 grams of carbohydrates, and maybe the carb ratio is 12, and that, computes into some decimals, which are no fun to deal with and present practical problems in patients who can take insulin in unit increments. And so for the correction here, the blood sugar is 227 points too high, and maybe their correction factor is 42, so that's 5.4 units. And so you add all this up, and now you're at a little over 13 units of insulin in this situation. And until about 7, 8, maybe 10 years ago, I used to really think of insulin pumps as glorified calculators that delivered insulin, because they essentially did all of the math, because this is difficult math, and it was just a huge burden for patients to do this. So that's fast-acting insulin. A quick note on basal insulin. So we're not going to talk too much about basal insulin, and that's because it's easier. An insulin pump does not have basal insulin, so patients don't use basal insulin when they have an insulin pump. Whatever their basal insulin was, it gets replaced, and it gets replaced by this steady drip, drip, drip rate of whatever their fast-acting insulin is, whether it's Aspart or Lispro. And in theory, you could think about this as you take however much basal insulin they're on and just divide that by 24, and that would give you a basal rate. The rate is always specified in units per hour. So if they were taking 24 units of glargine, their basal rate would be 1 unit per hour. Now, that's theoretically. In reality, that's not how we calculate, or at least how we set the initial settings. We combine all of their insulin, and we sometimes have to reduce how much, knowing that the pump will allow them to use a little less insulin, and we sometimes reconfigure. Some patients are on way too much basal insulin and not enough short-acting insulin. So there's some calculations that have to be done there, and we could maybe go through that in a future session. But that's just to demonstrate the principle of you're taking their basal insulin and you're dividing it into some basal rate. And these days we have amazing technology, which we call automated insulin delivery. And essentially what that is a dosing algorithm in the pump, and it adjusts the basal rate automatically at a certain frequency, usually about every 5 minutes, sometimes a little different, in response to whatever the patient's glucose is at any given time. This has some major advantages. So the biggest advantage is a reduction in hypoglycemia. So if the patient's blood sugar is dropping, for example, overnight, if the patient's using, if they were on glargine prior to the pump, like once they've taken that insulin, that ship has already sailed, right? There's nothing they can do except eat to raise their blood sugar. With automated insulin delivery, that drip, drip, drip rate will slow down, and it will often just stop. So there will be no insulin delivered, and then as the blood sugar rises, it will start again. And then pumps now have various ways of helping with hyperglycemia. So whether it's after a meal or a patient forgot to dose, it can give more insulin via the basal rate. But as of today, patients still have the responsibility for carb coverage. You have to cover carbs. Someday that may change, and it may be changing a little bit now, but it's still definitely the case. Your patients will do better if they're covering carbs. So some advantages here, like I mentioned, pump does all the math. It's really great for patients who are insulin sensitive, who need to receive, fractions of doses. So that's why pumps are almost ubiquitous in pediatrics and in type 1 diabetes in general. Patients always have the pump with them, so they always have insulin. They don't have to remember to carry it with them. They'll use just one insulin instead of two, and sometimes that can help offset some of the cost of a pump because that can be an issue. Most patients will use less insulin with a pump than they do with subcutaneous injections. A general rule is 20 to 30%. I find that that's pretty much universal. Some patients will see even a greater reduction. And then pumps these days all have automated insulin delivery, which provides that protection from hypoglycemia, which is critically important. So I think this is my last slide, and this is about the risks. As we've talked about some benefits of pumps, but there is a serious risk, and it's the most important one I want you to consider when you're thinking about patients who have a pump or who might use a pump. And this is a patient of mine with type 1 diabetes in her 60s. She's been on a pump for years. I don't know if you can see here at all, but where the blood sugar is trending down on that early morning of the 4th, and then it starts to trend up. The pump is turned off. That's what that little circle with the square is. And in this case, I think she forgot to turn it back on, or she had a problem with the site that she was trying to troubleshoot. And that's the main thing to be aware of, is there's a site where the cannula is attached to the body, and if there's a problem with it, if there's a kink in the cannula under the skin, if it comes out from under the skin completely, if there's an occlusion in the tubing, for whatever reason, if the site doesn't work in the setting of type 1 diabetes, patient will essentially receive 0 insulin because, again, they're not taking any subcutaneous basal. And when that happens, their blood sugar will rise in a linear fashion, and it will be very high, and that is a dangerous situation. It does occur regularly. Patients will have site failures, and they just have to recognize them, and they can fix it, or they can give an injection. There's all kinds of strategies to use to help them navigate or prepare for that eventuality. This patient did not realize, and she tried to give insulin later. You can see all of these little doses, like 6.38. Those are doses that she tried to give. They were ineffective. This patient ended up in the hospital with an extremely serious hospitalization. So that is the number one thing I'm considering with a patient who's going to start a pump is whether they can safely and rapidly identify site failure. Site failure and decay, that's the real risk. So who does what? I've always told patients with the pump, your responsibility is your blood sugar and your carbs. And then it's my responsibility to take care of all these things that we talked about. Correction factor or insulin sensitivity factor, the carb ratio, the target, which is pretty easy. I've mentioned it as 100 primarily for the math. Pumps now we can use 120 or 110, but it's always in that range. Have to program a basal rate, and then there's one parameter we didn't talk about, which is active insulin time, and it's relatively straightforward. It varies a little on the pump, but you can generally always use 3 or 4 hours. That's just an estimation of when the patient takes a dose of insulin, how long that insulin should be expected to last. It's primarily just factored into the calculations that the pump uses when knowing if any insulin is left in the patient's body still working, and it will show them that as something called insulin on board. And the patient's part has gotten easier with continuous glucose monitors. So the blood glucose monitoring is not as difficult as it used to be. Now there's a CGM involved almost always. And the pump has immediate access, so patients aren't, they used to have to push a bunch of buttons to enter their blood sugar. Now the blood sugar is, or the glucose is always displayed on the pump. But carbs are still the primary piece that's left, and covering carbs is still critically important. And so that is where we're going to bring Megan in next.
All right. Shout out to Dr. Turcotte. When we were coming up with this session, we were debating, like, do we review the different types of pumps and what do we do? And when I got his version of the presentation, I was so excited because our goal truly is to help make diabetes technology, diabetes information, diabetes care accessible to the primary care provider, the clinics that you're in. Diabetes cannot be entirely a specialty disease. We're grateful for our specialists. We're glad we have them, but we have too much of a population that needs help. As we talk about technology and diabetes, I just quickly want to note my dad, early on in his early 20s, went to a conference in California and came back and decided that he thought the personal computer was going to be the next big thing. And he opened the first computer store in Utah with my mom, and they watched the technology change from where the computer was kind of this boutique type thing that, businesses may use and other stuff like that, to watch it transition to where obviously everyone has access to a computer now. And I want you to keep that in mind as we watch this technology, because you may be thinking, oh, a CGM. Hopefully you've seen our previous CGM presentation. We need to empower all healthcare providers to take part in the technology advancements that we have to make it more accessible to everyone. My focus is going to be in type 2 diabetes. When we look at automated insulin delivery straight out of the standards of care in 2026, we know that automated insulin delivery is the preferred delivery method over multiple daily injections or traditional pump infusion for not only patients with type 1 diabetes, but adults with type 2 diabetes, children and adolescents with type 2 diabetes, or any other form of insulin deficient diabetes. This is the preferred method. So I got a little creative here. When you look at all of the letters that we like to use, it made me laugh as I was typing this sentence out. So automated insulin delivery in research outperforms CGM alone. Super grateful for CGM. Unfortunately, it doesn't outperform automated insulin delivery for A1C and time in range in type 2 diabetes. Click. Roger's my slide, so he's going to keep us target.
Gotcha.
I do want to also point out that one of the things that time in range and A1C doesn't reflect is quality of life. You hear from these patients, and yes, obviously their quality of life improves when their A1C improves and time in range improves. We see that from we're constantly focused on complications and other things like that. But the day to day for many of these patients are like, wow, I am not so consumed with this anymore, the anxiety over it and other things like that. So if it's best, why isn't everyone doing it? Well, one of the biggest reasons that we understand is a clinician knowledge gap. That's why we're here. And this isn't saying that we need, well, we do need more endocrinologists, by the way, but we don't need everyone to be an endocrinologist. We need everyone to be an advocate. Other things that get into the way are finances and insurance. I know from our previous presentations, this is a specific focus of this group that has to be addressed. Patient education level. For many of us, especially those of us in FQHCs or other places, other people that we've heard from through this series, we work with very low educated, language barrier, other issues that get in the way. And this can be a perception that keeps people from accessing automated insulin delivery. And going hand in hand with that is the socioeconomic level. So, what I want to encourage you to consider is if you're not doing this or embracing this, jumping in can help with health disparities. Click. I, over the course of my career, I've always used the starfish analogy, the quintessential kid walking along the beach, throwing in starfish, and someone asks him, "Why are you doing that? Look at all these starfish that are going to die. It won't make that big of a difference." And the kid looks back at the guy and says, "Well, it matters to that starfish." This is an analogy that I repeat over and over again in my mind. You may not be there for everyone, but jumping in can save that starfish and improve their quality of life and outcomes. Click. So getting started, what would this look like for you in your clinic? First of all, if you haven't watched our CGM episode, what's the word I'm looking for? Um, Make sure that you start to become comfortable with CGM. There is no automated insulin delivery without continuous glucose monitoring. So start to get comfortable with CGM. That's step one. Next is start to familiarize. Dr. Turcotte and I could have gone through all of the different pumps and completely overwhelmed you with information. In the end, what he chose was understanding pumping in general. And yes, all of the pumps have different nuances, little different buttons clicked here and there. Trust me, I screwed up with some understanding some of the different pumps. But jumping in and just understanding basic pumping can prepare you to familiarize yourself with any of the devices. Click. There is a great website, Diabetes Wise, that allows you to go in and put different pumps or devices in and compare them. It's a resource that's available. Click. So now that you've done CGM, you've familiarized yourself, pick something, meet the reps, develop a process, and mostly identify a patient that you feel can be someone that might be a great start for you. My bare minimum, and I truly mean bare minimum, I think a lot of specialists would be shocked at the level of education and socioeconomic status of people that I put on automated insulin delivery. My bare minimum is that they need to know how to manage a smartphone. And generally speaking, if they know how to download apps and manage a smartphone, I will find that they are appropriate for automated insulin delivery. Click. So we at Family Health Services right now primarily use Omnipod 5. I would like to point out that all the different pumping systems have different algorithms that they use. And that is something that's undervalued. Most people are looking for tubeless or this or that or the other. And truly, the algorithm is what drives how effective it can be at managing their blood sugars. I am not naive enough to say that the Omnipod 5 has the best algorithm. We're going to see in our case study a Tandem report. Tandem does microbolusing throughout the day in addition to other pump systems. Omnipod does not. But I can tell you that it's hotly debated online. I love getting into the chats online to see people say, no, you need to do this pump. No, you need to do this pump. And this one's my favorite. Personally, I've seen a patient change from a tandem to an Omnipod. I've seen a patient change from an Omnipod to a tandem or whatever it may be. And it's just finding what works for that patient. If you'll click, Roger, I don't know where
Yep.
they get the marketing material from, but this is generally what it looks like in working with patients. You try and find an actual picture of someone realistic. There is so much wrong with this picture. The G6 is on ski wampas, but it made me laugh because this is truly where we're at. You can see the details of the Omnipod 5 there. I'm going to just basically fast forward down to the end where the reason that we have chosen to focus on the Omnipod 5 for now is because it goes through a pharmacy benefit. It is not
Mhm.
durable medical equipment. I believe Beta Bionics and some others are headed this direction, but this means that you can send a prescription to the pharmacy for an Omnipod 5 starter kit plus the pods and that will be filled at the pharmacy the same way an insulin pen would be filled. It is considered an insulin delivery system. Someone from that company should get a gold star for figuring out how to manage that because it is not considered an insulin pump. It's an insulin delivery system, which makes it so much more accessible and affordable for patients and less hair pulling for providers who have to jump through hoops of C-peptides and all these other things to get durable medical equipment covered. So, as Dr. Turcotte said, one of the things we want to demystify is understanding carb strategies. So, you're going to see a variety of different reports. This is a glucose report, and this is a patient who's using an Omnipod pod. This is also a patient that I saw when she had gestational diabetes, came back a decade later with blood sugars regularly over 400 and would occasionally remember to take insulin and drop into the 250s, but most of the time her blood sugars was above 400. If you're thinking about getting started with automated insulin delivery, find that patient because anything that you will do will improve their blood sugars, even if they're not carb counting. And for her, she couldn't remember to take her insulin. She lives in a trailer, low socioeconomic status, low education level. But with the support of her family, she could get this pod on every 3 days and her blood sugars within 6 weeks dropped to an estimated A1C of less than 7. Here you can see that to my shock and amazement, she also started putting carbs in. And so you can see the 100 grams of carbohydrate listed in the carb line and the bolus that went along with it. This is beautiful. This is not what you would expect most of the time. Click. You can also see this is a patient who is a more realistic looking view as to what traditional carb counting would look like. But she brings up a very important point for a lot of our patients. And what happened is I would pick the day before we go through this data together, and I would say, okay, what did you have for dinner? And her 8 p.m. 60-gram meal was actually closer to 120 grams of carbohydrate. And so before you go adjusting settings too quickly, it's important to assess what's going on with this patient. And she, like many of our patients with type 2 diabetes or obesity in general, struggles with the shame and guilt associated with admitting to herself that she is actually eating that much carbohydrate. And so something to be aware of in traditional carb counting. Click. So one of my favorite things, and pump companies are catching on to this, this is actually the only way the Beta Bionics pump works now, is basically preset doses. You can go in and you can program a small meal, a large meal, a medium meal. Sometimes I'll program specifically like their breakfast, if they eat the same breakfast every day or the same drinks from Dutch Bros or whatever it is that they get. You program it in so they can just push a button and they don't have to stress about worrying about the carbs. Um, in the end, something is better than nothing. And so even if they're just, and you can see I'm doing a 1 to 15 insulin to carb ratio as an example here. But if they even put in something, it's going to prevent a higher spike and they get into the habit of doing it. That's more important to me than the accuracy of it. And I tell them that straight up. I don't care. Put something in and we'll get there. Next. Sorry, I'm trying to hustle. So this is the something is better than nothing strategy, where they didn't put carbs in, but every pump on the market will have a bolus wizard, a use sensor button, something that automatically corrects their blood sugars. And if I can't get them to put carbs in before a meal, I'm like, I just need you to press this button as many times as you would like to. The pump or the pod will prevent them from stacking insulin. And so I will take what I can get because something truly is better than nothing than their blood sugar staying high for too long. Click. So you can see this quote that I really wanted to end with and focus on as outside of systemic barriers, we know cost is a concern. We know that a location, resources, there's barriers to accessibilities. But I would like to challenge you all and challenge the healthcare providers you work with to not be the gatekeeper of this technology. Even if you don't feel that you can manage it, it should be a conversation that you should be having with your patients saying, hey, you would benefit from this. I'm not sure that I can help you manage this, but if you want to consider traveling somewhere, whatever their resources may be, or hey, I've never done this before, but I'm happy to walk this with you and figure it out along with you if you want to try. I know as healthcare providers, we don't like admitting that level of vulnerability, but this is such a resource that we need to start to get a better understanding of, or our patients, especially in our rural areas and communities, are going to be left behind. Oh, 1 minute over, Lindsay. I'm sorry, but we're done. Go team.
Nice work.
That's great. We're gonna really want to keep time for our patient case today, but if you can stop share, there we go. Let's just open for a couple questions, and you can either unmute or you can put those in the chat. Brian, I see you're unmuted. Let's start with you.
Yeah, so this morning saw a patient that has Omnipod and patient has Libre 3, but the two are not talking to each other. I use the
That would
CGM to inform my reprogramming of her basal regimen to stop the low sugar she's been having, but it'd be really nice if they talk to each other and get the AID mode that you're discussing. How do I get the
so
two to talk?
So you have to use ones that are compatible. Right now, the Omnipod is only compatible with the Libre 2 Plus, not the 3. It's coming down the line, but it's not there yet. So you can either switch your patient to the Dexcom G7 or back to the Libre 2 Plus. Kind of a pain in the butt, in my opinion. But the technology advances and they have a hard time keeping up communication with each other. And with Apple systems, it's even more of a struggle most of the time.
Boo. That's why I couldn't find it, huh?
Yep, sorry.
Okay.